to say thank you for inviting me to speak to the SIR-RFS group here. I commend you all for being interested and motivated enough to participate in these things. So I'm very, very thankful and very bright-spirited about the future of our field here if we have people like you all are participating in this. But we'll proceed on with my lecture. My lecture is the role of the interventional radiologist in the diagnosis and management of renal vascular hypertension in children. I have no financial disclosures to discuss. But during this talk, we'll discuss some objectives here. The imaging and endovascular treatment options for children with renal vascular hypertension. First, we'll go through the non-invasive diagnostic imaging techniques, the pros and cons of each, and the limitations and benefits of each. In addition, following that, we'll talk about the endovascular diagnostic as well as the endovascular treatment techniques that are available to address children with renal vascular hypertension. We'll discuss the various indications, the limitations, as well as some of the procedural aspects that are entailed in treating children with hypertension. So what is hypertension in children? Well, primary hypertension is a diagnosis of exclusion. It's actually increasing in number in children over the recent years, probably because of the obesity epidemic, particularly in older children and teens. Primary or essential hypertension is, like I said, a diagnosis of exclusion, whereas secondary hypertension is the vast majority of etiologies in children. Greater than 80 to 90% of children that have hypertension have an underlying secondary cause. It's up to us as healthcare providers to try to elucidate what that underlying etiology is. And one of those underlying etiologies specifically is renal vascular hypertension, and that's the point of our talk. And you'll notice that this is clearly the opposite ratio as it is in adults, whereas in adults, greater than 90% of their hypertension is essential hypertension, and we just shrug it off as we don't know why you have a hypertension. And in a minority of cases, there's an underlying secondary cause. But again, in children, the vast majority have secondary causes, of which renal vascular hypertension is a significant proportion. So what is the prevalence of renal vascular hypertension in children? Some say it's responsible for up to 10% of all children with secondary causes of hypertension. It's probably as high as 20%, particularly in the young infants. So it's probably inversely proportional to the age. The younger the child is, it has hypertension, it's probably related to, it's more likely to be related to renal vascular hypertension, whereas the older they are, it's less likely to be related to renal vascular hypertension. Again, young children typically aren't obese, whereas older teenagers can be morbidly obese, and thus, although that's we don't accept that as a specific cause for the hypertension, but that is an increasing correlation. So renal artery stenosis is the third most common pathologic condition following renal scarring, as well as underlying glomerular disease, that gives rise to significant hypertension in children. It's second only to coarctation of the aorta as a correctable cause of hypertension in children. So therefore, it's important to diagnose renal vascular hypertension because we can correct it. So what is renal vascular hypertension? It's hypertension resulting from a lesion or lesions that impairs blood flow to any part or all of one or both kidneys. So what's the underlying pathophysiologic basis? Well, if there's a stenosis or an alteration of blood flow, there's decreased renal perfusion pressure, and therefore ultimately leads to hypoperfusion. As a result, it really leads to a decrease or a dysregulation of the renal autoregulation, stimulating the renin-angiotensin aldosterone system. I'm not going to say that anymore. I'm going to say the RAS system, okay? So with that comes a release of renin and the production of angiotensin II, leading to hypertension. That's why ACE inhibitors work, right? The cause for renal vascular hypertension can be actually extrinsic or intrinsic to the renal vasculature itself. We'll discuss that in a few moments, all right? So, for example, if we look at this angiogram here in a child, we see wedged delayed enhancement or hypoperfusion distal to area of focal stenosis. Here we have the radiologist on where there's a arrow leading to a focal area of stenosis in a third level branch, whereas everything else is already perfused in the parenchymal phase. You notice that the segment that's perfused by this branch is not perfused as briskly at this point. Thus, hypoperfusion leading to the renin-angiotensin-aldosterone negative feedback system. So what are the various causes of renal artery stenosis in children? There's fibromuscular dysplasia. There are various syndromes that are associated with renal artery stenosis, which include neurofibromatosis, tuberous sclerosis, Williams syndromes, and various other syndromes. Vasculitides, such as Takayasu's or polyarteritis nodosa, can lead to underlying renal artery stenosis. These are intrinsic abnormalities related to the vessel itself. Extrinsic compression, such as from neuroblastoma or other retroperitoneal tumors, or other causes, whether it be radiation or umbilical artery catheterization that causes trauma and therefore dissection and or trauma itself, and even renal transplants, renal artery stenosis because of the underlying technical anastomotic stenosis. So, other causes of renal vascular hypertension that aren't related to renal artery stenosis, anything that causes alteration of flow or dynamics can lead to hypertension, such as in this case, we see a child with multiple aneurysms emanating off the renal artery itself. So with aneurysms, it alters the renal perfusion. Notice here that there's hypoperfusion of this segment during this phase of arterial imaging as a result of the altered hemodynamics related to the underlying aneurysms. In this case, this is an arteriovenous fistula. You notice that here, during the arterial phase, we're already seeing the renal vein, and therefore we're seeing steal and hypoperfusion of the mid and upper pole of the right kidney, leading to hypoperfusion and thus hypertension. So anything that causes alteration of flow dynamics and therefore leading to ultimately hypoperfusion or decreased perfusion pressure to the renal parenchyma can lead to renal vascular hypertension. Other causes, like we said, can be extrinsic. In this case, extrinsic compression of the kidney due to a subcapsular hematoma compresses upon the kidney, and you notice here, which is the classic Page effect. Frequently, the Page effect may not be so readily evident, but in this case, this child only had a single kidney, so therefore, whatever affected this single kidney affected his entire renal vasculature. So, renal artery stenosis. Let's talk about various causes of renal artery stenosis, okay? So, fibromuscular dysplasia is actually the most common cause in children in the Western society, right, of renal artery stenosis. 60 to 70% of children with renal artery stenosis will have fibromuscular dysplasia. The most common cause actually varies in literature, such as in the Eastern literature or Sub-Saharan Africa. Aortitis or arteritis is the most commonly reported association of renal artery stenosis. Why is that? Probably because the underlying arteritides aren't treated so early and therefore will lead to fulminant vasculitides that affect systemic vasculature, specifically the renal arteries. And therefore, that will cause the increased occurrences of renal artery stenosis as a result of the vasculitides compared to that of the Western society, where most vasculitides are probably treated early on and therefore don't progress on to end-stage vasculitis. So, what does FMD look like in children? Okay, well, as you guys are familiar with, the appearance of FMD in children is actually significantly different than that of the classic string of beads appearance of that seen in middle-aged females here. Renal angiogram, you see the classic beaded string of beads appearance, and on CT, again, we see that classic bead string appearance, right? That being said, in children, and in my experience, it doesn't look like that. It's not classic. It doesn't give us that string of bead appearance. The vast majority of them, when we're dealing with typical FMD in non-syndromic children, all right, so we're going to take out those syndromes or those vasculitides. That's when FMD typically occurs, right? It's typically a focal short segment stenosis, right? It looks like a focal isolated web. In this case here, early branch, focal segmental stenosis with classic appearances of post-stenotic dilatation. In this case, again, segmental focal stenosis, not the string of beads, post-stenotic dilatation, and notice again, decreased perfusion. And when there's decreased perfusion, what happens? Well, it tries to collateralize, and you notice that there's all these small curlicue vessels trying to collateralize beyond the stenosis in order to help perfuse the renal parenchyma beyond the stenosis. So when I do a renal angiogram, I'm not necessarily looking for the stenosis itself, although when I see it, it's very easy when I put an arrow on it. I'm actually looking for the secondary findings of renal stenosis, and that leads me back to the stenosis itself, such as delayed perfusion or these collateral vasculature. In a study that I published several years ago, the majority of FMD or renal artery stenosis in children actually may occur in branch or accessory renal arteries and does not involve the main renal artery. That has significant implications for imaging. We'll talk about that in a few moments, okay? So, evaluation of children with suspected renal vascular hypertension, right? Unexplained hypertension after a complete medical workup, then we start considering renal vascular etiologies, right? So, the history and physical exam, we got to elucidate the onset of the hypertension, do a physical exam to see if there's an abdominal bruit. We measure blood pressure measurements from both arms and both legs to make sure that they're symmetric, right? We evaluate for evidence of end organ sequelae, whether it be cardiac abnormalities, renal dysfunction, neurologic dysfunction, right? And then I always typically will get a 24-hour ambulatory blood pressure monitoring measurement. It's where the child literally walks around with a blood pressure cuff that blows up every 15 minutes, and it's recorded by computer to see what their blood pressure is. They do this while they're awake. They do this while they're asleep. All right. We also evaluate them their urine and their various other laboratories. And ultimately, after we do all this workup, we're going to do some non-invasive imaging studies. Okay. Following the non-invasive imaging study, then we'll proceed on with a catheter angiogram with intent to treat. So this is the classic progression in which I perform or I'll evaluate a child with suspected renal vascular hypertension. So what are some factors for increased likelihood of finding a renal artery stenosis, right, that's detectable by angiography? Well, a child with stage 3 hypertension, which is the greater than 99th percentile, already has a 50% chance likelihood that they have renal artery stenosis without us doing anything else. If they're in the 99th percentile for their age and weight, then they already have a greater than 50% chance. So let's go backwards and talk about the diagnosis of hypertension in children. So what is hypertension in children? Well, it's not a set number like it is in adults. In children, we have children based upon infants all the way up to teenagers. The determination of their hypertension is based upon whether it's above the 95th percentile for their age, weight, and sex, right? So if it's above the 95th percentile for their age, weight, and sex, it's considered stage 2 hypertension. If it's above the 99th percentile, then it's considered stage 3 hypertension, and they're in this class here. So anywhere from 90th to 95th percentile, that's really what we call pre-hypertension, all right? So they're stage 1, stage 2, stage 3. So when they're in stage 3, it's a very high likelihood that they have renal vascular hypertension with that alone. But when we start compounding other additional things, it really increases the likelihood. Are there secondary symptoms or complications of a high blood pressure, such as end organ, hypertension requiring 2 or more medication classes, diagnosis of a syndrome with a high association with vascular abnormalities, such as, the neurofibromatosis and things of that nature, or vasculitides, right? Known or suspected previous vascular insult, and various other things, all right? So let's go on to imaging of children with suspected renal vascular hypertension. We'll start off with some non-invasive imaging techniques, all right? At this time, there's no reliable non-invasive screening test, all right? Just because it's not reliable doesn't mean it's not useful, okay? The purpose of the non-invasive imaging test is to screen and survey the abdomen for other potential secondary causes or explanations, such as abdominal masses or renal masses, right? Renal scarring, or other systemic vascular bed abnormalities, right? If you find those, then we have an explanation for the child's underlying hypertension, right? If we identify an abnormality of the renal arteries, great. It permits us greater planning for catheter-directed intervention, right? So what are the non-invasive imaging modalities? Obviously, there's ultrasound and Doppler, there's CTA, there's MRI, and nuclear scintigraphy. We'll go over the pros and cons of each one of those. So obviously, ultrasound and Doppler, the advantages allows us to screen for renal sizes. Are they symmetric? Is there scarring? Is there hydronephrosis? It's non-invasive. There's no need for ionizing radiation, which is a benefit. It's relatively inexpensive and readily available. In this case, we see a child with hypertension. On the right kidney measures 11.9 centimeters. The left kidney measures 8.8. So there's significant scarring and atrophy of the left kidney, right? She's had a history of multiple urinary tract infections, reflux, renal scarring. That's probably the explanation for hypertension as opposed to renal vascular hypertension, right? So what are some positive findings? Well, findings such as we use Doppler. Here we have increased peak systolic velocity. People always ask me, well, what is an abnormal velocity? I do not know what an abnormal velocity or elevated velocity is for a child. We really try to compare it to its internal norm. So you measure the aorta, right, peak systolic velocity, and then you measure the renal arteries. And if the ratio is greater than 3, that's clearly abnormal. If it's anywhere from 1 to 2, it's probably normal. 2 to 3, it's that gray area, okay? But you look for secondary evidence, right? There's increased peak systolic velocity here, greater than 300 centimeters per second, right? The intrarenal RIs are decreased, and you'll see a parvus tardus waveform. Why? Because it's blunted due to upstream stenosis, right? In this case, there's an elevated renal aortic ratio greater than 3, really signifies that this patient has renal artery stenosis of the main renal artery. Right? What are some limiting factors? Why don't we just use this all the time? Again, limiting factors for Doppler and ultrasound, it's really operator dependent. It can be quite time consuming. You know, a good study could take upwards of an hour. That's a lot of patients. Right? A negative study doesn't exclude the potential for other intrarenal or branch vessel stenosis. Right? If the diagnosis is obtained, we still requires an intervention. So it really doesn't help us here, right, as far as a negative study, right? Other limiting factors, 20% of exams are technically unsatisfactory, even in experienced hands for adults. So this dramatically increases for an uncooperative child, obviously, right? A complete examination of both renal arteries achieved is only 50 to 90% of cases for adults under the best of circumstances, right? And then stenosis of accessory or small segmental intrarenal arteries commonly go undetected. Like I discussed earlier, a significant proportion of renal artery stenosis actually involves branch vessels, which are extremely difficult to find on renal Doppler, particularly in children. So we'll go to CT. Some advantages. It's minimally invasive, only requires a peripheral IV. It's readily available. They produce beautiful 3D images. Right? It's also able to evaluate for the entire abdomen for alternative diagnosis. Here's an example. Beautiful CT. Clearly shows renal artery stenosis with post-stenotic dilatation of the left renal artery, the main renal artery. Right? Here, in this case, the CT was able to show us that there's diffuse abdominal aortic abnormality involving both the origins of the renal artery in a child with a middle aortic syndrome. Explains why the child has hypertension. Right? What are some limitations? Well, exposes the child to ionizing radiation. It really has limited resolution, particularly with the intrarenal parenchymal segmental vessels. It shows us the main vessels beautifully, but after it starts branching out, it's really difficult to assess whether there's renal artery stenosis or not, right? Although there's 90+% sensitivity and specificity in adults, again, adults predominantly involve the main or ostial portion of the renal arteries. This doesn't necessarily translate very well to children, where, again, a significant number of renal artery stenosis occurs in branch vessels. Again, the normal CTA doesn't preclude a segmental level abnormality, and thus requires that we continue to proceed on. Right? Furthermore, requires obviously the use of contrast agent. Right? There can be false positive findings because of resolution, as well as a CT only really gives us a static image. It doesn't give us any flow dynamics. It doesn't allow us to see that there's delayed perfusion in a segment of the kidney, as we saw in the angiograms earlier. Right? Here's an example of a false positive CT. Here we see the right renal artery. Don't see the left renal artery at all. Here, axial images, we see the right renal artery beautifully. Don't see the left renal artery at all. I do the angiogram. It's perfectly normal. It's just the phase of imaging and the resolution. So this is a false negative. Beautiful renal angiogram there. All right? So here's a false negative. There's a renal artery stenosis. It's right there. I'm not going to call that on a CTA because that's, why isn't it over here? Why isn't it over there? Why isn't it everywhere? The resolution just isn't there. So here's the why. It's a tough call. This is main renal artery, segmental branches, lobar branches. So it's a third or fourth level branch. It's no wonder we can't see it. So there's a high-grade stenosis there. All right, so false negative. So here's a child with hypertension with symmetric renal enhancement. No problem there, right? Here's the angiogram. The right main renal artery is completely occluded and is only filled by collateralization. Well, we wouldn't know that on the CT because the CT is performed and delayed, and the enhancement has already caught up. There's no hemodynamic or physiologic flow pattern that's available with CT. This kidney was entirely perfused via collaterals, and the main renal artery was completely dissected chronically, obviously. How about MRI and MRA? What are some advantages? Well, obviously no ionizing radiation. Again, minimally invasive. It allows for multiplanar imaging and maximum intensity projection images. Gives us really beautiful angiographic-like images. There's no requirement for iodinated contrast, right? Gives us beautiful images. Beautiful. Main renal artery stenosis, there's a correlating renal artery stenosis, right? So what are some limitations? Again, the limitation is the resolution, particularly with branch vessels, all right? It's very susceptible to artifact. People only show you the beautiful images that, at talks and whatnot. They don't show you probably a good percentage that are not as ideal as the images they use for talks. Right? In children, it often requires deep sedation or anesthesia because an MRI or MRA can take upwards of an hour, right? You're not going to get a young child to be able to cooperate for that long, right? And again, normal studies does not preclude segmental level stenosis. How about nuclear scintigraphy, right? The principle is that you give an ACE inhibitor, it alters the renin-angiotensin-aldosterone system, right, compared to the baseline. It reduces the renal perfusion pressure in a patient with renal artery stenosis and therefore reduces the glomerular resistance and leads to hypoperfusion and differences in radiotracer uptake, right? The advantages of nuclear scintigraphy, it's minimally invasive. It provides functional or physiologic information that you can correlate with that of the other anatomical imaging tests. Its limitations, again, is it really gives us no anatomical detail, right? Although it can be sensitive, the specificity in adults with renal artery, it's really not an ideal. It's really not all that sensitive, even in adults, all right? It can give us false positive results when there's bilateral disease, right? Patients with decreased renal function have a higher percentage of non-diagnostic tests to begin with. And again, limited anatomical detail. So let's look at some pictures here. So, notice here, on the graph, we see delayed in the perfusion of one of the kidneys. And on the angiographic phase, we see delayed perfusion on the right. It eventually catches up, but there's delayed perfusion on the right, particularly early on, and we can see it on the graph. CT shows why there's a high-grade stenosis in a segmental branch. Angiogram shows us that correlating segmental branch, high-grade focal stenosis with FMD, poststenotic dilatation. So that correlates with the physiologic findings on the nuclear scintigraphy study. Here's another girl, 9-year-old girl with hypertension. Notice, clearly delayed enhancement. Wow, right? Implies renal vascular abnormalities. So in this case, I saw this. I didn't even bother doing any other imaging tests. I feel like a fool of that because I was like, man, this is renal artery stenosis. Girl's got hypertension, delayed enhancement. Boom, let's do the angiogram. Well, I was a fool. I did the angiogram. couldn't find the renal artery. Now we see why there's delayed enhancement, because the renal artery was absent or had been dissected. Right? So let's move on to angiography. All right? Angiography for renal artery stenosis. The advantages: it remains the gold standard for diagnosis. Okay? It has the highest resolution possible. It gives direct detection of arterial stenosis. It allows us to evaluate small branch vessels with selective catheterization. It gives us physiologic or hemodynamic flow patterns, right? In addition, it allows us access route for percutaneous angioplasty if we find something, right? What are the limitations? It's obviously invasive, right? Frequently requires deep sedation or general anesthesia in younger children, right? There may be some age or size limitations, potential complications, particularly with small children. They're easier to dissect, thrombose, right? It can actually exacerbate the renal dysfunction if we use too much contrast. And even if we do an angioplasty, there can be recurrent stenosis, right? So, yield of positive angiography nearly 50% when the various factors are present, like we discussed earlier, right? So, other diagnostic tests for hypertension in children. When I do an angiogram on a child, if I don't find renal artery stenosis, I'll proceed on to renal vein sampling just to make sure that we've covered every base, right? So the diagnosis of lateralization in children when we do renal vein sampling is difference in ratio of one side to the other greater than 1.5 indicates significant lateralization. It does give us, some prognostic value, but it's not very specific because any underlying parenchymal abnormality can lead to an abnormal renal vein sampling, such as reflux nephropathy, along with renal artery stenosis. So, what are some treatment options of children with hypertension? Obviously, there's medical treatment, then there's surgical revascularization and or nephrectomy, and then what we're going to talk about, percutaneous catheter angiogram and angioplasty. Occasionally, we'll have to use stenting as a salvage procedure for a complication. All right, so what's out in the literature? There's not much out there, to be perfectly honest, right? Renal artery interventions in children, European group here. They formed 8 patients, mean age around 10, 5 FMD, various vascular disease, right? All were taking 2 or more medications. Angiograms showed 9 lesions. The results: 6 out of 8 had complete correction, right? With a mean follow-up of about 39 months or so, right? 1 of 8 improved, and 1 was just resistant. So, in that small series, it was pretty effective. Group out of England, they took all comers, right? 33 children, mean age somewhere around 10 or median, right? Half of them had bilateral renal artery disease. Nearly half of them had interrenal disease. And nearly a third had bilateral and interrenal. So, what's the results? They did angioplasty in 48 of them, right? What are the outcomes? Well, 50% achieved some form of improvement in blood pressure control, right? The ones that received the best were the greatest improvement, 11 out of 13 with main renal artery stenosis alone. 7 were cured and 4 were improved, right? 6 out of 33, or nearly 20%, had some complications. The vast majority are minor, mainly groin site hematoma, but cost doing business, right? Group out of Italy, back in 1995, 36 children, vast majority had FMD. All the ones with FMD were normal intensive. The ones with syndromes were a little bit more resistant, which is concurrent with my experience as well. Another group here, 20 children, 20 PTAs and 16 children. Again, vast majority had FMD. Some had underlying syndromes or vascular disease, right? 11 patients with main renal artery stenosis, 7 were normal intensive. So, significant were cured, right? 2 children with segmental PTA, again, both cured. So, 3 patients with multiple lesions. So, when there are multiple lesions, it's typically associated with syndromes. When there are syndromes, it's a systemic abnormality, not just a vascular abnormality. So it's very hard to treat a systemic diffuse vascular abnormality, right? Underlying milieu for children with neurofibromatosis or various vasculitides is already behind the 8 ball, and it's not just that of renal artery stenosis. Group in India, right? Vast majority of them had underlying vasculitis or aortitis, right? Again, they had wonderful results. 27 had bilateral involvement, and greater than 50% or nearly 2/3 of theirs had significant improvement, whereas about less than 10% had no response. Group in South Korea, again, 16 children with all comers, 19. So we're getting the feeling here that, you know, if we're doing angiograms on children with hypertension, we're finding renal artery stenosis. If it's a single lesion, there's a good chance that we can significantly improve them. When there are multiple lesions, again, it's just more challenging. Not necessarily because of the angioplasty itself, it's because the underlying abnormality or the vasculopathy that the child may have in the kidney or systemically. And here's my early on experience when I was in Cincinnati, right? And most recently, a group in Philadelphia, 19 hypertensive children. Again, nearly 40% of them were cured. 3 out of 18, so 10 out of 18 has significant improvement. 8 failed responses, right? And this is how they broke down. 5 out of 7 with neurofibromatosis had cure improvement, whereas 5 out of 11 at a FMD had cure improvement. So there's really no good large studies that combines everything together. So I guess, really the moral of the story is that, again, in my experience, is that we're going to find renal artery stenosis in children. The children that are otherwise healthy generally do well. The children with syndromes have a little bit more challenging effects because they're more prone to recurrence and or have other etiologies that compound on that may lead to their hypertension, not necessarily only their renal vascular abnormalities. So when we do angiography and PTA or angioplasty, what are our goals? All right. My first goal, actually, when I do angiography and angioplasty in children, is A, to stabilize their blood pressure. All right. So frequently, so you have to define what is success. If a child is on 2 medications, now requiring 3 medications, and they're still uncontrolled on their blood pressure, and we do an angioplasty, and now, although they're still on 2 or 3 medications, at least their blood pressure is controlled, I think that's actually considered some elements of success, where we stabilize their blood pressure on their medication. Another level of success is that we're actually able to reduce the number of medications or the dose that's required, and the ultimate success is that we cure them and they no longer need any medication. But if we only hold ourselves that cure with no medication is required, I think that's a little too high of a bar to set, where even children with multiple medications, if we can stabilize them, at least that was better than the trajectory that they were on. Other goals that we can hopefully achieve is to postpone or avoid the need for surgical options at all. Stabilize or even preserve the renal function. All right? So who and why? So who gets an angiogram? All right? Children with stage 2 hypertension, greater than 95th percentile, should get an angiogram. Children with uncontrollable hypertension, children with evidence of end organ dysfunction and hypertension, those with increasing requirement of medication, for instance, if they're been on a single drug for quite some time and then now they're needing 2 drugs, it shows me that there's decreased efficacy with time, and therefore we should probably elect to do. We can be a little bit more aggressive. I always tell family, if a child's on a single medication, I think an angiogram is very safe. I don't think, we can do that, but they're on a single medication. If it's controlling their blood pressure, I really can't make them much better than that, right? But when they get on 2 medications, guess what? They're on the road to 3. So we can already see the trend there. So I usually hold off on doing angiograms on children unless they're on 2 medications. That being said, if they're not compliant, then that may drive me to be a little bit more aggressive, right? Some families have a desire to reduce or eliminate all medications altogether, and therefore, we discuss the potential risk and complications of angiogram and angioplasty, and then we proceed accordingly, right? When we have to try to preserve renal function, we see dysfunction proceeding on, then it's best to be more aggressive, right? And obviously, if we can demonstrate a simple single lesion, and there's a good likelihood for significant benefit, we'll proceed on with angiogram and angioplasty. So, we talked about this earlier. Algorithm for suspected renal vascular hypertension. We'll start off with medical management. If it's well controlled, we'll maintain the follow-up. Escalation of medications 2 or greater, or acute change, will proceed on to non-invasive imaging that will map out and exclude alternative diagnosis. We'll proceed on with a catheter angiogram. If it's amendable, we'll proceed on with percutaneous angioplasty. Right? If it's not amendable or a complication of PTA, they may have to move on to salvage stenting or a surgical bypass. And if there's a negative angiogram, I'll proceed on with renal vein sampling as the final step of turning over every stone before we give them a diagnosis of essential hypertension. So we'll start off with a flush aortogram. The flush aortogram allows us to evaluate the origins of the main renal arteries without the threat of spasm as the potential cause for renal artery stenosis as a fake out. So in this case, we do the aortogram. We see beautifully the main renal arteries are widely patent. After we do the aortogram, we'll select out the renal arteries and perform dedicated renal angiogram with various projections in order to remove the overlap. In this case, we can see that there's a high-grade stenosis of a branch vessel, delayed perfusion of the upper bowl. After we identify a stenosis, we can cross the stenosis with a low profile, with a 018 or 014 wire, advance a low profile balloon, angioplasty, and follow it up with a angiogram. Before, after, right? So during my angiograms, I'm evaluating for possible complications. What are the possible complications? Obviously, dissection. We can rupture it. There can be recoil stenosis. And how do we address these complications? I always make sure I have some nitroglycerin or TPA available for immediate use if we go into spasm or thrombosis. And if we dissect it, we reinflate the balloon, hopefully lay down the dissection flap, and if not, then may have to lay down a stent. Here's an example of main renal artery stenosis in a child with fibromuscular dysplasia, high-grade stenosis of the main renal artery, post-angioplasty, widely patent. Some examples of renal artery stenosis involving branch vessels or even accessory branch vessels. Here, we see aortogram, main renal arteries, widely patent. We see that there's an accessory renal artery, delayed perfusion of the upper pole. We select it out. You see that there's a high-grade stenosis of a branch vessel of a accessory renal artery before and after. And you go, well, Dr. Vo, there's still narrowing there. Well, remember, I'm not dilating it to the post-stenotic dilatation. This is post-stenotic dilatation. I want to dilate it to the size of the expected vessel. Example of renal transplant with anastomotic stricture. Again, typically due to technical factors, high-grade stenosis, renal transplant with hypertension, angioplasty it relatively easily, wide open. We go well. So, renal transplant with pre and post Doppler. Pre-angioplasty, elevated velocities with a parvus tardus waveform and a decreased RI. Post-angioplasty, normalized velocity and normalized RI to 0.6 with a normalized waveform. There are risks that come with angioplasty. In this case, this looks like a pretty straightforward, again, anastomotic narrowing. easily crossed. Angioplasty, there we go. Doesn't seem all that difficult. Post-dissection, I couldn't tamp it down by reinflating the balloon. Had to lay down a stent, and that's all right, right? So what do we do following angioplasty? What do we do, right? So obviously we admit them to the hospital. We'll monitor their blood pressure, right? We adjust their medications on a PRN basis. You got to be careful with hypotension. If we angioplasty them, again, if they have a bunch of medications on board, they can become hypotensive because the underlying half-life of their antihypertensive medication, right? So if they become hypertensive, give them fluids. If they become excessively hypertensive, I'm really concerned about thrombosis, and therefore I get an immediate Doppler, right? I'll continue them on some anticoagulation overnight on a heparin drip to minimize the risk of renal artery thrombosis following my TPA. This is balanced against the risk of a hematoma or other bleeding issues at the puncture site, obviously. And then I'll typically initiate aspirin for about 3 to 6 months. And then, we'll obviously monitor for complications of arterial puncture. So, other than renal artery stenosis, as the etiology for the perfusion abnormalities, there can be also arterial fistulas that lead to hypoperfusion or underperfusion or steel that can lead to hypertension. In this case, this child had a hypertension, had a biopsy done several weeks prior. You can see the arterial venous fistula form right there. Here's the angiogram. Arterial venous fistula, artery phase, venous phase, AV fistula, early draining vein. We can just go down there with a microcatheter, drop a coil, post coiling, angiogram, no longer see it. Hypertension was resolved, right? So that was a post-traumatic AV fistula, right? So with AV fistulas, right, or post-traumatic AV fistulas or post-traumatic injuries such as in biopsy, complications can include that hematuria, steel, the pseudoaneurysm or rupture, and hypertension. Initially, most AV fistulas will spontaneously resolve on their own. So if you see it, just wait. 70% of them are asymptomatic and will spontaneously close. However, if it doesn't, it does require that we selectively coil them. All right? So what's up with a negative angiogram? All right? So after negative angiogram, like I said, I'll proceed on with renal vein sampling. I really want to do this to make sure that I've given the child every effort prior to giving them a diagnosis of essential hypertension. It's done under the same sedation, right? So in this case, the CTA shows that the renal artery is really widely patent and that there was still an accessory renal artery to a native kidney. The child had a history of nephrectomy on the right, but they didn't remove the left, right? So they were concerned that the transplant was the etiology for the hypertension. The Doppler showed, and as well as the CTA, showed that the renal artery really was wide open. But I noticed that there was this residual renal artery perfusing the nubbing or residua of the left native kidney. Go in there, do a left renal vein sampling. The ratio was abnormally high, showing that this was the etiology for the child's underlying residual renin. So they had to go ahead and do a nephrectomy on this. So in conclusion, renovascular hypertension is a common cause of hypertension in children. Anything that alters blood flow, whether it be stenosis, a fistula, or extrinsic compression, can lead to hypertension, right? Although non-invasive imaging evaluation, there's no ideal non-invasive imaging study yet. Doesn't mean that it's not helpful. There's a role for it, particularly as a means to exclude alternative diagnosis, right? The type of study performed is really dependent upon local practice and comfort for the non-invasive imaging techniques. Catheter angiogram with intent to treat angioplasty is a safe and effective treatment option. All right, some references there. All right, and thank you for first of all participating in this and paying attention. And I'll open it up to some questions right now.
Thank you very much, Dr. Two questions came up throughout your
Sure.
talk. First one was with regards to the angiographic findings that you see with patients with neurofibromatosis type 1 versus
Sure.
patients with muscular dysplasia, is there an angiographic difference between the two, or do you generally know about the neurofibromatosis?
Yeah, well, first of all, we know a child who has neurofibromatosis because it's a clinical diagnosis, right? But yeah, there are differences in the appearance of angiographic abnormalities associated with children with neurofibromatosis versus those that are otherwise healthy. All right, children that are otherwise healthy, like in the examples that I've showed you, have the typical focal. I'll roll back to this. Okay, have the typical focal stenosis. Excuse me. Whether it be just a typical focal stenosis here, a focal stenosis here, whereas everything else looks normal, a focal stenosis here, typically unilateral. Children with neurofibromatosis, like I talked about, it's a systemic abnormality, so therefore they will frequently have multiple abnormalities, right? It'll be bilateral. It can involve the main renal arteries or segmental branches, but it's frequently multiple abnormalities, as well as they can develop aneurysms as well. So classic neurofibromatosis abnormality of a kidney would be aneurysms inside the kidney in a child. So whenever I see it, if I were to take a case, they showed me an angiogram of a child, there's aneurysms inside, I start thinking of vasculitis or neurofibromatosis. Whereas, again, the classic FMD in children is typically just, again, this focal web, right? Isolated focal web, and they're otherwise healthy. All right? Good question. Thank you.
Another question that came up was a more technical question.
Sure.
Use a 014 wire.
Yeah.
What system do you use? What sheet size do you use? How do you make those decisions as you start on?
Good question. Okay. So again, I have no disclosures. I have no financial interest. So I'll say some brands that I use just because that's what I use. Okay. So typically, in most children, right? So the largest, the main renal arteries in most children, is going to be at maximum 6 millimeters. Okay. So a 6 millimeter diameter angioplasty balloon can be performed through a 4 French sheath. All right, so it's a low-profile system, whether it be a monorail or over the wire. So my perfect example is I will get access into the common femoral artery, obviously, put a 4 French sheath, and you notice that I run the sheath after I do the catheterization here. I run a 4 French sheath all the way into the main renal artery. This is a 4 French sheath. It's really only 1.3 millimeters in diameter, right? It should be more than accommodating. That wire that I get out there has a 2 centimeter floppy tip. 014, I'll use a balance. If it's an 014 system, I'll use a balanced middleweight or a BMW. If it's an 018 system, I like to use. I like using a nitrix wire, but it really doesn't matter. But I'll tell you, use a wire that has only a 2 centimeter floppy tip, because again, the rest of this is stiff, which allows us to bring the balloon over relatively easily. Angioplasty, I have my sheath there. I can do the post-angioplasty angiogram right there and then to prove that I haven't dissected, ruptured, or other complications. In addition, anytime I do an angiogram in a child, particularly that's less than 2 years old, I anticoagulate them with about 50 units of heparin per kilogram. Why? Even if I don't do an intervention. Why? Because that sheath inside the femoral artery can lead to thrombosis. Right? So if they're less than 2 years old, I anticoagulate them, right? If they're older than 2 years old or 15 or 20 kilograms, I don't anticoagulate them unless I'm going to do an intervention. So in these, whenever I plan to do an intervention, again, I start off with 50 units per kilogram with the option of giving another 25 to 50 units. I wanted to get their ACT up above about 220 or so because I want to minimize the risk of post-angioplasty thrombosis due to the trauma that's being caused by the angioplasty. Again, good question, and thank you. Again, no financial disclosures to make of.
In the event that you do deploy a stent for whatever reason, what sort of therapy do you use afterwards? Do you use Plavix, aspirin, one or both?
I'll use aspirin. I'll use aspirin. Obviously I'll anticoagulate them aggressively afterwards, and then I'll just continue on with aspirin and aspirin, and then follow up closely with Doppler. Children heal very briskly, unlike in adults, where a lot of it has to do with atherosclerotic, right? Children will endothelialize pretty well, and if we just keep that platelet aggregation away. And again, I have no evidence. I have no evidence for this whatsoever. There's just not a lot of experience out there that I can draw from for my antiplatelet regimen. But when I first started doing this, when I was much younger, much more cavalier, I wanted to start using Plavix, and then I thought about it, with and I discussed this over with the hematologists and other medical people. They were very concerned about the increased risk of just hemorrhage, because they said, use one antiplatelet. If you need it, then we can add another one, but don't start off with, too many antiplatelet due to the risk of hemorrhage. And I think that's reasonable.
And another question was, in the patients who do get improvement from the angioplasty, but maybe not complete resolution, who do you work closely with a pediatric nephrologist or a generalist?
Absolutely. If a child has hypertension, they really should be evaluated and worked up by their again, my best partners in this are my pediatric nephrologist. Okay, so So I'm not an expert. I'm not prescribing them their antihypertensive medication. That is out of my league, and that's probably out. That's just not. Just not the best care that I can provide for a child. The pediatric nephrologist really is an expert in the antihypertensive medications, and I really do partner with them on that.
One question I missed it earlier with regards to the sheath size that you used. Do you use a 4-French straight sheath?
Well, I'll use a 4-French braided sheath, and again, I use an Ansel, ANSEL. 4 or 5 French Ansel sheath. It's a braided sheath that's shapeable. It goes over. It has 2 inner dilators that it works over an 035 or an 018. So the dilator can accommodate an 018 wire and works nicely over it. It's braided, so it can so it's relatively resistant to kinking and whatnot. And again, it's just what I use.
What lengths will you generally?
They typically come in 40 centimeters. 40 centimeters is more than enough in most pediatric patients, and even in young adults.
I think that's all the questions I received.
Beautiful.
Thank you so much for your time. Thank you, everyone, for attending.
My pleasure. Thank you very much, everybody.
We'll be in touch about future lectures.
All right. Thanks a lot, man. All right. Bye-bye.